Continuation of Pathology, Lecture 3, talking a little bit about antiphospholipid antibody syndrome. This is another associated disorder with bleeding. So, the sometimes call this APS. It's with acquired hypercoagulable state, means that they have an increased risk of thrombosis. You are at risk for recurrent thrombosis, repeated miscarriages, although there was a little bit of a disclaimer on this, which I'll go ahead and read. It says that, I don't know if I can find the slide on it. It says, fetal loss does not appear to be explained by thrombosis, but rather seems to stem from AB-mediated interference with the growth and differentiation of trophoblasts, leading to the failure of placentation. So, also cardiac valve vegetations and thrombocytopenia. So, there is primary and there is secondary APS, or antiphospholipid antibody syndrome. Primary is not associated with an autoimmune disease, whereas secondary does have an underlying autoimmune disorder, such as lupus. In fact, they used to call it lupus antiphospholipid antibody syndrome. So, you can look at this in vitro and in vivo. So in vitro is like in the test tube, and in the test tube, it's going to be in a hypocoagulable state, because obviously in the vitro there's no platelets and there's no endothelial cells, and platelets and endothelial cells is what involves coagulation. So in vivo, however, it's going to be in a hypercoagulable state, because there are endothelial cells and there are platelets. Now, a thrombus, when you do have a thrombus, there are 4 possible things that can happen. 1, it can propagate. 2, it can undergo embolization. 3, it can undergo lysis and disintegration. Or 4, it can undergo organization and recanalization. I'm just going to read off some more points here that were made. The diagnosis of this disorder is you measure AB to the B2 glycoprotein. Normal individuals will have low concentrations. So a normal person is going to have low concentrations of AB to beta 2 glycoprotein, whereas pathologic individual will have pathologic levels found in a patient with APS. So you'll have, I know that's not very specific, but that's what it says in the PowerPoint, so they'll have more. Phospholipid ABs are necessary but not sufficient to cause full-blown antiphospholipid antibody syndrome. False positive tests for syphilis should raise suspicion, but by no means is sufficient for diagnosis. So if you get a false positive on syphilis, that might be an indication of this. Also, so far the studies have shown no clear clinical differences between patients with primary versus secondary APS, one thing I was talking about over on the side there. Now we're talking a little bit about the objective that says the concept of thrombus formation, the fate of thrombus, and the consequences of arterial cardiac thrombosis. So you got to remember Virchow's triad, 3 abnormalities that lead to thrombus formation. 1, endothelial injury, single most important factor. 2, stasis or turbulence of blood flow. And 3, blood hypercoagulability. And in order for thrombosis to occur, there needs to be at least 2 of those 3 things. So there's just not a whole lot here left to cover. It's all kind of review. So maybe I'll go ahead and call that good. Let's see, anything else? Oh, I guess there is a little bit on disseminated intravascular coagulation, also known as DIC. This is the sudden widespread intravascular activation of systemic activation of thrombin, leads to formation of thrombin and fibrin thrombi, followed by fibrinolysis. Can cause diffuse circulatory insufficiency, especially effects in the brain, lung, heart, kidneys. Can be acute, subacute, or chronic. Consumption, coagulopathy, platelets, and coagulation. Factor become used up. So if you used up all the platelets and all the coagulation factors, then the person might start having this problem. Or rather, when you have this problem, it uses them all up. And yeah, that's pretty much all we got here. I'm gonna call that good.